Good morning, I'm Jen Audley. I'm the coordinator of the Community Health Improvement Plan for Franklin County and North Quabbin, and this is a CHIP Network Progress Report meeting. Really excited to see you all here, and we have some super cool people. All of you are super cool people, but I especially want to point out that we have Nikki Kalasa from the State Office of Rural Health here today with us. And we have folks from the Bay State Family Medicine Program. There's a whole bunch of them. Can you raise your hands and wave so people know where you are? We have quite a few members of the CHIP Steering Committee. If you're on the CHIP Steering Committee, can you raise your hand so people know who you are? We have Aliana Marietta from the Greenfield Reporter in the back there. She's going to be covering this meeting for us today. And Jaden Grazik from GCTV is here recording for us today. And we have several people who are here for the very first time at their very first CHIP meeting. Can you raise your hand if this is your very first CHIP meeting? So make sure if you are a CHIP veteran that you make those folks feel welcome, because that's part of being part of the CHIP. Today we are talking about 2 of our 13 health priorities for 2024 to 2028. We're going to be talking about digital equity first, and then we're going to be talking about access to healthcare. We'll take a little break in between those 2 sections. So if you have stuff that you need to do, that's a good time to plan on. I think the break is going to be at about 9:45, 9:50. The slides and the links to all the resources that we talk about will be on the FRCOG website at the URL that is on the calendar for today's meeting. And I also wanted to just quickly note that, so the CHIP is both a network, a coalition of people, and also an actual real plan. And we're in the middle of a 5-year plan that goes from 2024 to 2028. And that means that it is time for us to really reflect on how we're doing and make some adjustments about things that are going differently than we thought that they were. So for the next couple of months, probably until the summer, I'm spending a lot of time thinking about that, and I may be asking for your help. But today, what I want to focus on for our CHIP intro is a little review of our model of health. This tree, this picture of the tree, is one that we chose because it represents how we think about how health works, that health is a system that is interconnected, and that there are lots of interconnected factors that affect our health, including where the tree grows and what kinds of things we put into the soil. And so in this picture of the model of health, the watering can represents our ability to improve the conditions in which the tree grows. So what the CHIP does is really focuses on the level of the watering can. We think about what can we put in that watering can? How often should we water the tree? Who gets to hold the watering can? Who gets to decide? How do we know whether it's working or not? And so I put one of these trees on your table so that you could look at it more closely and think about how what you are interested in and what you need for your health and what your community needs for its health fits into this tree. We have on our CHIP tree outcomes that reflect the priorities that we chose for this 5-year plan. And I'm going to switch to the next slide so you can see more close up how that looks. And I have these bursts that are going to show up. So the bursts are kind of showing where the focus of today's meeting is. It's about abundant care providers, it's about digital equity, civic engagement, intergenerational networks. That's kind of what we're focusing on today. But there are all different kinds of outcomes that can come as a result of making an effort to improve health. And so I gave you the trees for your tables that don't have the leaves labeled so that you could think about how your work shows up in the tree and what kinds of outcomes you envision for this community and what kinds of outcomes you're working towards. And I also wanted to draw your attention to the 4 categories that are kind of the main branches of this tree, because that's an important part of this model. That today, one of our focuses in the healthcare access part is on clinical care, and that is what a lot of people think about when they think about improving health. They think about going to the doctor, taking medicine, visiting the hospital, whether you have to go to the emergency room, and that is an important part of health. That is the clinical care part of health. But there are 3 other main branches of our tree. One is the physical environment, the place where you live. One is health behaviors, things that people can do, and their ability to do those things. And then a big part of the tree is social and economic factors, things like education, social support, employment, the things that make it possible for you to be able to attain health. So I am interested in just a quick show of hands. Raise your hand if you feel like you work in the social and economic factors part of the tree. Raise your hand if you feel like you work in the health behaviors part of the tree. Yes. What if you work in the physical environment part of the tree? And what if you work in the clinical care part of the tree? What if you work in more than one of those categories? Great. Okay, awesome. All right, so today we're going to do 2 topics. We're going to do an update on digital equity, and I'm going to introduce that part, and then later I'm going to have 2 folks, three people actually, talk a little bit about the specifics of the work. So when we chose the priorities for this chip, the state was investing really heavily in digital equity, meaning infrastructure and programs that were intended to help people across the Commonwealth get things like high-speed internet, have devices, and get help using those devices so that they could access the opportunities that those tools unlock. And this graphic is from the Western Massachusetts Alliance for Digital Equity. And interestingly, it also uses kind of a tree metaphor. And their take on it is that the digital divide prevents people from even being able to participate in the tree. And so they're trying to make that chasm smaller so that people can get in on health and employment and transportation and childcare. For the chip, what we felt like we needed to do was to focus on making sure that the statewide efforts and the statewide investment reached people who live, work, study, get their health care, socialize, all those things here in Franklin County and the North Quabbin, especially people who are more disadvantaged. The good news is that since 2023, a lot of good stuff has happened in the digital equity realm. Too much for me to talk about today. But the bad news is that the funding for a lot of those programs came from sources that were like ARPA, that were COVID recovery funds that are now gone or are almost gone. And federal support for sustaining digital equity work has really fallen away. So today what we're focusing on, because there is so much, is a few examples that show how the organizations that are leading this work locally have adjusted their programming and how they're working together to continue and keep building on the work that they started with that initial investment. So this is the context, is that at the beginning of our planning, like in 2023, this thing called the Affordable Connectivity Program, or ACP, was a huge focus for a lot of our community partners that were working on digital equity. And what the ACP program, which was a federal program created by the FCC, did was it increased the number of options that low-income people had for getting high-speed internet for less, for like $30 a month, and discounts on devices. And the FCC created the program, they funded it, and they supported a massive outreach effort. And by the end of 2023, there were 23 million people signed up who then they were all low-income people. They had signed up and they had these low-cost internet plans. But then, in 2024, the FCC ran out of money to fund the program that it had created. And they said, we need more money for it, and we need Congress to authorize the spending. And as it turned out, despite bipartisan support, the ACP Extension Act, which would have been a $7 billion investment to keep that program going just through 2024, didn't pass. And so what that meant here, and all across the country, but we're most interested in here, is that there were all of these people who had signed up for this program, and all of a sudden what they heard was, you're gonna get a higher bill if you wanna continue having service with the internet provider that we just convinced you to sign up for. And what it meant was that folks who work with low-income people here spent an enormous amount of time and energy fixing that problem, helping people find new ways of staying connected, helping them figure out how to pay this much higher bill that they weren't expecting to get. And it was really kind of a hard way to start out. But there have been a few really cool ways that local organizations decided to adapt and adjust to this new reality of like, oh, there was this great federal thing and now there's nothing. So one of the things that happened that was a short-term strategy, this is like, okay, how do you help the person who had good internet and now is gonna lose it or have to pay a whole lot more, was to increase the availability of mobile hotspots that had their service plans already paid for. The idea here was to provide temporary, flexible internet access to people who were facing barriers to affordable, reliable broadband. So our United Way, the United Way of Franklin, Hampshire, administered this pilot program in partnership with the Alliance for Digital Equity and Mobile Beacon, with funding from the Massachusetts Broadband Institute. And in this picture, you can see Rich Vaden, the United Way's digital navigator for Franklin County, who just recently did an impact report on this program, which just wound up. Rich can't be here today, but when I spoke with him, he told me that Stone Soup Cafe was a superstar in this pilot program. And as it turns out, Stone Soup Cafe has some folks here today, and Kirsten Levitt has offered to be put on the spot to say a few words about it from their perspective. So Kirsten, I'm gonna just give you the mic and invite you to tell us a little bit.
All right, so the first thing you have to know is that Kirsten Levitt did not do the lifting on this project at all. It was Sarah Hillier. She's our Director of Community Engagement, and she couldn't be here this morning, so she wrote me a 3-page report. Okay, talk about overachiever. She's amazing. No, like quite frankly, the staff at Stone Soup Cafe is always looking at the issues of connectivity. And quite frankly, we started this on a very selfish level. We were trying to get digitized outdoors, because all of our programming happens outdoors. Curbside pickup for meals happens outdoors. Shopping for our Everybody's Community Store happens outdoors, and we wanted to have a connected system. Guess what? No Comcast connectivity on Hope Street. No Comcast connectivity for the church building. No Verizon connectivity. And GSET, love them, they're an internet provider, but could not get us outdoor connectivity. But Rich Barton could, Vaden could. And then he said, oh, and we can do that for you and our entire community. So it started out on a very kind of selfish level, like how do we get more advanced in collecting data and interacting with folks and making sure that we're doing what we need to do, and then all of a sudden we're like, oh, and we can help our community too? Right on. So we know that there's critical need for connectivity because it affects employment and education, access to healthcare. I just did a healthcare online thing this morning for a new doctor. I was like, wow, what if I wasn't home and when I didn't have my own internet or hotspot, right? It was like, oh, wow, that really does make sense. Just managing essential services, and what about if you need, you need to call 911 and you don't have internet connectivity? Yep. And also to reduce isolation, like those all good reasons to have connectivity. And of course we partnered with United Way of Franklin County and with Rich and the Alliance for Digital Equity. And we started that in July. And since July, we gave out 27 hotspots. They went like hotcakes. We kept 3 for ourselves so that we could use them when we're out in community. So we had a total of 30, and guess what walked in the door yesterday? Another big box that we're about to give out. And just some interesting statistics of the 27 participants, 19.25, I don't know how we get there, were unhoused, 19.25 were senior citizens, 19.25, these people were, percentage, were BIPOC. And then adults between 18 and 64 was 15.5%. Unhoused BIPOC people, 15.5%. People sharing a household, not quite 8%. And senior BIPOC people, not quite 8%. I thought those were really kind of interesting metrics. I've always, as the ED of Stone Soup, I always look at our metrics and we can see the ground, and it's watering in our clientele, and this was just another confirmation of that. And so we're looking ahead to these future devices going out, and we're developing an eligibility model for a device distribution pilot. So we have laptops and iPads that are going out as well as hotspots. And they're going to address barriers that a smartphone cannot necessarily address, like job searches and resume building, navigating government service portals, replacing outdated or non-functioning technology, simplifying long-form communication and educational tasks, digital literacy and skill building for users, and legal and civic engagement. So these are all things that the pilot will address, and we're just so grateful to United Way, to Rich, and to the Alliance.
Awesome. Thank you, Kirsten. And one other thing I want to mention about the hotspot pilot is that the United Way was able to find funding to extend those 1-year service plans to be 2-year service plans for 9 of the organizations that they gave hotspots to, based on whether they really used them or not. And the 97% usage rate of the Stone Soup Cafe hotspots qualified them to get that additional extension. So the other part of the Alliance's shift around the ACP was to really go in hard on legislative advocacy. And I'm going to just mention that Corinne Coriat from the former office of Natalie Blais, First Franklin District's legislative director, is here with us today, just walked in. And I believe that Corinne has announced that she is going to run for that seat. So if you'd like to continue that. And so the Alliance and partners filed 2 bills which the CHIP has supported. One is, these are in the 2025-2026 session. One is about preserving broadband service for low-income customers. That is basically a way to create those low-cost plans for low-income customers by requiring most ISPs, internet service providers in Massachusetts, to do that. And the other one is an act establishing a commission to develop a statewide credentialing program for digital navigators. Both of those bills have done really well. Both of them got voted out of the committee. They were heard in a committee, and then they were voted out of the committee favorably, and they are now with their respective Ways and Means committees. And you can see there is Rich, again, testifying at the State House along with colleagues from the Alliance for Digital Equity. So now I'm going to stop talking for a little bit, and I'm going to hand it over to my colleague Ted Harvey from the FERCOG. Ted is the Economic Development Program Manager, and he is going to talk about the municipal side of the digital equity work, and he's going to introduce Donna Giselle.
Great. Thank you, Jen. Hello, everybody. When Jen asked me to talk to you all about digital equity, I have to say the first thing I thought was, I kind of forget what I did with digital equity. And the reason is because it's been a while, and that's a good thing, because my role was really to do the planning stage. So it's very cool to hear what Stone Soup Cafe is doing now, because our role really was to kind of set the stage and let people run with it. So that's kind of where, so we're gonna take a quick step back, and I'm gonna talk to you just for like 2 minutes about what we did at the FERCOG for the planning piece of this. So Jen mentioned that there was funding from the state, which actually was federal funding, which is no longer in existence. And part of that was to do these digital equity plans, which is where we came in. We did digital equity plans for all the towns that are highlighted. The green up there are part of a regional plan. The orange are part of a smaller regional plan, and then each one of the blue towns have their own digital equity plan. They're all on our website if you're interested in going to look at those. And so when that was completed, there was further money to do implementation funding, and I'll talk to, which is mentioned here, I'll mention that in a second. But the digital equity plans, really what we were looking at was a number of things. One was devices, that's come up. The biggest one that came up was affordability. That's come up over and over again, especially with the end of the ACP that Jen already mentioned. So once we had these plans in place, then there was the cool part from the state was that there was implementation money tied to any town that did these plans. So you can see it's more than $250,000 was awarded for various things in our region, which is great. And one of the cool projects that's ongoing, that started before this even began, was the Cyber Seniors Program. And so that started with GCC and Greenfield, and now it's expanded to, I think it's 6 towns now. Donna's going to talk a little more about this. And so that program has really kind of taken it started before us, but it's taken this, the planning piece of it, taken the implementation money and really run with it. So I'm going to have Donna come up because I was only told to spend 1 or 2 minutes. It's been 1 or 2 minutes. And Donna's going to actually talk about the very cool project that they've been working on at GCC and hope to continue for a while.
Thank you.
Yeah.
I'm a bit shocked.
So,
I am so used to that. Like, I always ground myself before I touch anybody these days. So I'd like to give a shout out to Ted, who's really helpful in terms of figuring out how we could do a group cyber senior citizen tech support project within some of these towns. Because that was a little unusual to just break out funding for senior citizens and have that be a part of the program while the towns also pursued their own money. So thank you, Ted. So Cyber Seniors, I'd also like to give a shout out to Judy Waco, and I see she's back there. Cyber Seniors was an organization that started out with a bunch of young people who realized their grandparents didn't know how to use technology. They started a service program, and then they created a movie. And then Judy saw that movie, and in 2022 decided she wanted to do this work at GCC. And so the project started that way with work-study students, and it was really housed under GCC, which made GCC a really natural partner when the city of Greenfield was deciding to do some digital equity work, funding for senior citizens through the Department of Elder Affairs. And so that's how I came to be involved in 2023. And that program worked with workshops at GCC and the Greenfield Senior Center, and tech support at GCC and the Greenfield Senior Center. And then we also started working with libraries in towns outside of Greenfield because we saw this need. Then the program ended, as these things always do. I'm thankful for the CHIP Network for funding some gap funding so that we could continue planning and working with senior citizens after that program ended and before this one began, which is currently running in the towns of Charlemont, Coleraine, and Leiden, as well as New Salem, Wendell, and Northfield. So I figured it out, and there's 39 miles in between the towns from one end to the other. I'm just gonna open up my phone because I do have my little note card with some numbers on it. I'm gonna look at what Jen put for me. All right, so, going over the background, let's see. So, in the first round of funding, we were able to serve 176 people with workshops and 216 tech support individuals. This grant, we've currently done 17 workshops so far. It started in July. And these are now taking place throughout the towns rather than being centered on GCC. And we've served 116 individuals with tech support. Another aspect of our work is the Intergenerational Film Festival, which is, right here is last year's filmmakers and buddies. It was an amazing event, and I certainly encourage you to come if you are available on April 23rd of 2026. We will be holding that at GCC. We partner older people with a younger person, and they do a short video, and it was just amazing. I guess the thing that I would like to focus on in terms of this program is that it's more than being about tech support. It's also about relationships, and we've seen people really blossom in their relationships. It's good for the younger people, and it's good for the older people too. They both get something out of it, so it's really important. I would say that mostly people are looking for help with their phones. People are really worried about security. I have worked with the Alliance for Digital Equity to request new devices sometimes for people. And the requests that we get are pretty amazing. Like, I just got a phone, I don't even know, this is my first smartphone, I don't know how to work it too. I'm a comedian and my personal website really could use some work. So we see an amazing amount of requests, and I guess one of the overarching things that I see, and it really was brought, I was reminded of it yesterday, is when I'm sitting with someone and they see me struggle to figure out why it is that you can't share your screen on Zoom on an iPad when you should be able to do that. Why you have to look at your pictures and put your document, it's crazy. And the person I was sitting with said, wow, I really thought that I was dumb. And it's like, no, this is hard. And there are a million ways to do it, and it's okay. The other thing I see is people don't want to touch them. They're afraid they're gonna break it. I broke a lot of computers back in the 90s. They're not so easy to break anymore. It's like, it's okay, give it a try. It's not you, you can do this. And I find that they leave just feeling a lot better about themselves. I'm really happy that we are able to offer these workshops now throughout the community, as well as GCC. So if you're a person that lives in Wendell, you don't have to travel to GCC to get a workshop. You can do it right in your local library. So there are a lot of great things about the program. I'm gonna leave it there. And if you feel free to ask me questions at the break.
Awesome. Donna, thank you so much. Ted, thank you so much. Judy, thank you so much. I hope this gives you a taste of some of the ways that people in our region are working together to be able to keep moving forward on digital equity. And I hope it inspires you to think about some of the ways that we might be able to do more in the next 2.5 years of our CHIP, despite the changing landscape of funding for this work.
Thank you all very much. Hope you got a chance to connect a little bit and get a snack. And if not, you can still go get it. That's fine. So I'm Phoebe Walker. I'm the Director of Community Health here at the Franklin Regional Council of Governments. And thank you. And am as old as the hills and been with this CHIP since it started. So I'm here to sort of kick off our healthcare access goal. And here for our 5-year plan, our goal was expand access to healthcare. And there has been so much good progress. And we're actually very excited about this giant federal money you may have heard about, the Rural Transformation Fund, that is coming, that is a federal investment in rural healthcare access. So I expect there to be a lot more good stuff to talk about in the coming 5 years. And there's not, you can't always say that. So we have seen a lot of progress, and that includes the Community Health Center here, opening a new Turner's Falls site with Spanish-speaking doctor and nurse. We've got a mobile clinic that the health center bought, and we've got our fabulous family medicine resident program, which is now in its 3rd round of fourth. We're already at you guys are the 4th? Oh my goodness, okay. So we have a lot of fun with these guys because every year we get to take them on a bus tour to show them what does Franklin County look like before they disappear into their offices. And this photo here is a stop we made at the Good Neighbors Food Pantry in Charlemont. But I am going to stop talking about them and let them talk to you. So I think we're going to start by having Dr. Baldor, who's the chair of the family medicine program at Bay State UMass Medical School. Tell us about it, how it's going so far, and how it's working to make connections between that healthcare system and the community, and how it's training people who hopefully want to work in rural healthcare for the future. So I'm going to hand it over to Dr. Baldor. Thank you for being here.
Well, good morning, everybody. It's really a thrill for me to be here. I do have to say, I was just reflecting on that last talk, talking about smartphones and everything, and technology, how valuable it is. Absolutely true. And somebody once asked me not too long ago, what's your most valuable possession? And I thought for a minute, and I said, well, my glasses, because without my glasses, I can't see a thing on my smartphone, which is my second. That was it. The other thing I want to reflect upon is this amazing tree here and everything you guys do. And so I'm going to talk about family medicine, but just to start my comments on that is that, they say it right. It takes a village to raise a child, and but it really takes a community to train a family physician, because family docs are really interested in this tree, and so much of our money in this country and our emphasis goes into that little dot for clinical care. But this whole thing is health, and I think that's really what we believe in as a discipline. And so really thank you all for helping to train our residents as well on this journey. So
Nate has your clicker. So
there it is. Okay, so let's talk about who are we. So basically, the Department of Family Medicine at Bay State's only about 6 years old, and it actually came on with UMass Chan first. So the medical schools in Worcester was there for a number of years, and they developed a Western campus out here in the Pioneer Valley, and they developed that with Bay State Health. And so there's 25 medical students here get admitted specifically into this program. And by the way, that's to be expanding up to 35 over the next 2 or 3 years. So we're going to get more people out this way. But when they did that, they needed to develop a formal family medicine presence. And part of that was really thinking about the training of docs. And so it was the training of developing a family medicine residency. So we were actually here. Bay State did this really to really support Franklin County, support the medical center as well. So we're actually the only formal department that's not based in Springfield, which is really pretty neat. So because of that, we have a great voice with the mother institution. So our department's mission has been this: explore innovative methods for population health care delivery while educating PERCH students in the tenets of family medicine and community health. PERCH, by the way, stands for Population, Urban, and Rural Community Health. And that's what the medical student track is here in the Pioneer Valley. Hosting our family medicine residency, recruiting family docs to the Pioneer Valley, and then supporting our faculty to achieve their professional goals. Okay. So hit the whole thing. Yeah, thank you. Oh, go back. Can you back it up? Sorry. I'm quicker here. So a little bit of this, people often ask, what the heck is family medicine? People don't always know. And so in many ways, what we're sort of the old general practitioner who did everything that's been dusted off and buffed up, and we do a superb job of that. So what it means is we serve a social unit, we serve the family, all people in the family. This is a lot of the other specialties that you hear about in medicine, right? Like internal medicine just does adults, pediatrician just does children, OBGYN just does women, or an organist, a cardiologist that just take care of the heart, right? And we take care of the person. And so people ask, what do you specialize in? I specialize in caring for you. And that's what family docs do. And so that's the role we play as primary care physicians. And so therefore, family docs are the superb primary care provider. Go ahead. So we take care of the entire spectrum of clinical issues, really emphasis on acute and chronic outpatient. And thinking what we've done here is really the fact that so much medicine now has moved into the outpatient arena. We really need to be training and making sure that we can take care of folks in the outpatient arena. Along with that, just a quick example is when I was in training, diabetes has been around forever, right? And so, you know diabetes, know what it stands for, by the way? It stands for sweet urine. And so you go back a few years before I was in training, how do you tell if somebody had diabetes or not? You taste their urine. Sweet, they got diabetes. So anyways, technology has changed a lot. Not doing that anymore. But when I was in training, we had insulin and Zephyr. We had 2 medications to take care of diabetes. Now, there's like a gazillion medications to take care of diabetes and all kinds of different ways of doing that. So a lot of training has to occur in the ambulatory environment to understand these things. So that's what we're talking about along with this. Really engagement with the community, really to understand that tree we just talked about. And then of course, we do have a lot of specialists that we need to engage people in providing help. So how do you do that? What's that interface between what can we take care of? What do we need the advice from specialists for? Good thing. So we were the first family medicine training program in Western Massachusetts. Hard to believe that there's actually a lot of family medicine training in Worcester and Boston, but none out in this area. So we're the first one, and again, it's a partnership between the medical school and the medical center here. Now, why do we do this? The other reason why we did family medicine is we were looking at trying to address the primary care shortage in the area and doing family medicine is because 85% of those who graduate from their residency go on and stay in primary care, and 65% actually stay in the communities where they train. So that was really probably why we wanted to do family medicine. You talk about some medicine, pediatrics, people who do those residencies, they go on to subspecialize. They go on to become cardiologists. They go on to become hematologists and whatever. But most folks that train, do the residencies in family medicine, stay and do primary care. So that's what we're about. So we want to provide well-trained family docs who understand the healthcare needs of Franklin County. So I'm going to ask Nate to bring his clicker and come up here. So we started this residency program here just about 5 years ago, actually, and it's been wonderful, and we have some terrific, Chandra Hartman is the residency director. She couldn't be here today, but Nate's the associate program director. Dr. Macedo is actually a Tufts Medical School graduate who actually did rotations back when Springfield had its association with Tufts. Wanted to stay in this area, but there was no family medicine training in this area, so trained at the Community Health Center in Lowell.
Lawrence.
Lawrence, I was going to say, get the wrong L, get the L in there, Lawrence. And then we heard that there was a family medicine residency training program here. He came here. And this is partly also, even when we're training residents, but it's to attract folks, the attendees to be here to provide services. So I'm going to stop there. Sure.
All right. Thanks, Bob. So, no, I mean, I couldn't agree more with all of the introductory remarks that Bob just said about our specialty. And family medicine is a specialty. We're a specialist. We're comprehensivists, as opposed to being more partial or thinking about one specific organ or group of people. We focus on health systems. That's why we're here today. This is part of our residency curriculum. this week being back into the community and getting the CHIP update and being part of this. And we're here today to give an update on one of the CHIP priorities on increasing healthcare access. And a wonderful pediatrician, Dr. Barbara Starr, years ago studied this, and systems that prioritize primary care, and as Bob just mentioned, family medicine is the primary care specialty. Or between 85 and 90% of us practice that and take care of all ages and stages. When you focus on primary care, you decrease costs, you reduce health inequities, and you increase access. And it's been incredible to see that, not only in my training, but now as a faculty and teacher of this program. So I was inspired when I was a student, and then wanted to continue doing teaching in my role, and it was just a serendipitous that when I was looking for jobs and kept my eye back out in Western Mass, that when I graduated, the department and the program were coming online at the same time, and it's been a whirlwind of 6 years. So we practice right in front of the community hospital at 48 Sanderson Street. We have been so grateful for all of our community supports, from our foundation and donations that have helped, and the systems, both UMass and Baystate, that have helped us transform. We've taken over the entire second floor of the old Tap and Die building that is now our Baystate Health and Wellness Center, and our entire second floor now is family medicine. We are able to see a ton more patients and train residents in our program, which is really, really amazing. It's a 3-year-long training program. Most family medicine programs are 3. I trained at a 4-year program, and we started with a handful of residents, and we expanded now to 14, which has been great. And just like Bob has been saying, their education is not just in the 4 walls of the clinic, it's the entire region, it's our entire system. These are just a few of our partners that help educate these family doctors. But our residents are, taking care of folks in the clinic, they're seeing patients across the street, in the ED, in the birth center. They're getting that acute care experience in a different environment in Springfield, in the inpatient pediatrics and L&D floors. They work with CSO, they're at UMass Amherst, they're at the CHC of FC, they're all over the place, which is fun for learning too, as the residents are seeing patients across different areas. Our group now is 14 and growing. We have 4 third years this year, 5 second years, and 5 first years. And these are our 5 first years. We'll be speaking shortly, so I'll jump back to that slide. But our first class graduated back in July of 2025. 3 out of the 4 have stayed on as practicing physicians here in Connecticut County. Dan is currently wrapping up his addiction medicine fellowship out in Boston. But he's a Western Mass guy, and he's talking to us about coming back. So we might even be able to say we've kept all 4 of them so far, so it's pretty amazing.
What practices are these doctors at?
The 3 of them actually have stayed on to sort of help grow our faculty, so they're currently at Franklin with us. But we can't keep them all, so the idea is to eventually spread them out further where they're needed.
Wow, yeah, she's amazing. Sorry, Dr. Anderson is my husband's doctor, she is
Yeah.
amazing. We started with her when she was still in her residency, she's amazing.
Yep. No, yeah, Rachel and John are amazing, and Moss is amazing too. Moss's husband is an anesthesiologist in the area as well, so it's just the more, again, all about connectivity, right? And to train these family physicians, right, we need nurses, we need community health workers, we need MAs, we need teachers for all of this. So it just and then they
By the way, we got openings for MAs, we're just looking for a job.
We do. We need more to help support all the patients we want to see and train with our residents. And our residents come sometimes with families too, and it just snowballs the effect of what creating a teaching health center in a community can do. And that was sort of what inspired me to do this work. Out where I trained in Lawrence, I always was fascinated about the history and origin story, and how they started off with just a handful of doctors who saw a need in one of the poorest communities in Massachusetts, and that like 20 years later they have this like army of residents dedicated teachers, faculty and staff, and they have been able to increase access and help and do all the things that I was just saying, reducing health inequities and lowering costs by focusing on primary care. And I was like, we should do this in every community if we can. Why not? That's why we're doing it here in Franklin County. So what's next? So we are expanding. I was just telling the residents next week we'll be having our meeting. We offered over almost 100 interviews. We interviewed about 85 candidates for now 6 slots. This is the first year we're going to be actually able to take 6 residents to train with us. I feel like over a dozen, right, guys, have come up already. Because all of our interviews have been virtual for the pandemic and post-pandemic for equity reasons. But even over a dozen of them have traveled out to come and visit us, and it really just shows high interest. So I have a really good feeling about this year's match. We are also thinking about what could we potentially do to do some other innovation with teaching. Maybe doing some more areas of focus for a resident post-graduation, whether that's in addiction, like the fellowship that Dan is completing, sports medicine, hospitalist training, behavioral health, thinking about the other pockets in our system that need more clinical care and access and specialty. And we're doing that through a lot of multidisciplinary training. We've gotten many grants. We have a really powerful connection with our Department of Psychiatry and CSO to enhance the training and access of care to our residents in behavioral health. We are also the area health education center at Bay State Franklin, so focusing on the pipeline of training all healthcare professionals, including we were awarded a grant to train community health workers in rural settings. And we also now have a clinical pharmacist in our team, which is amazing, Anna Mortali. And she's starting to train pharmacy interns at our residency program. So we have lots of learners, and always welcome learners. We have the medical students with us all the time. I'm hoping to get some more trainees and medical assistants too, and it's just wonderful with all of the different opportunities we have for engaging our community, and I'm working on that next generation. All right, so without further ado, I'll bring it back to our first 2 residents who are going to come and speak a little bit, introduce themselves, and talk and reflect about their first 6 months of training here in Greenfield.
Yay! We're gonna need a bigger bus.
We're gonna need a bigger
You're
bus,
taking
for
6
sure.
Hello, everyone. So, but I'm Dan Sekulowski. I'm one of the interns here, and it's a pleasure to be here in front of everyone. So, like Dr. Macedo said, we were asked to sort of come up here and sort of talk a little bit about our experiences within the first few months of our program here, sort of getting more integrated with the community and sort of getting to see what medicine is like here in Greenfield. One of the things that I sort of particularly noticed was how transportation sort of affects healthcare, and that's something I noticed both in my medical training, but as well in my experiences here. So, primarily I've seen people who have to travel over, say, like an hour. In medical school, I think behavioral health was like an hour and a half if they didn't come to our clinic specifically to sort of get access. And coming up here, I see a lot of similar things where like public transport doesn't particularly get people to the clinics. And I went to UMass Amherst, so public over there to get to the college was awesome, but trying to get people to their appointments, to places they need to be, to community centers, to even the grocery store to get like nutritious food to sort of bolster their health. A lot of these like social and medical aspects sort of are seeing a lot of improvement that I've seen already here, but it's definitely something we could like, or I'm particularly interested in focusing on and sort of seeing as it advances. And I know in a couple of our more community medicine, or a couple of our elements that we've already seen. I've seen LifePath already work on a lot of like elder transportation. I know there's a lot of MedRide resources that we could also get people to their appointments, but it's just something that I think that Franklin County needs to expand, but I'm very happy to see so many people like putting forth that effort into getting people where they need to go. But, thank you.
Yeah. Hey there. I'm Patrick. And so, first of all, thanks for having us here. I appreciate it. We were asked to reflect on, what it's been like. It's been about 6 months now since we've been here, and how the community has, or how we've been able to observe the community, be integrated into the community. And I gotta say, ever since day one, I feel like we've been super welcome into the community. There's so many familiar faces we keep seeing over and over and over again, which is great. And I feel like that's really helped expose us to a lot of the needs of the community. In particular, we talked together and came up with things. I think we have a lot of similar things that we've seen and needs that the community has, needs. And so one that I focused on was a lot of our patients, I think, have this problem of food insecurity, which isn't, I don't think, specific to Greenfield in particular, but this community, and I think a lot of communities by and large have, a lot of food insecurity. So we do things like, we have a little questionnaire for some people to fill out about if they feel like they have, a good source of food, or if they're worried about food, or things like that. But we try to go beyond that. And, that first picture that we saw right there, we were at a food pantry, from the bus tour. And so, ever since day one, we've been exposed to it and seeing it, and I know how super important it is. And then even on Tuesday, we were, cooking lunch together right there. And, it's just, it keeps being hammered home how important it is to have access to food. Because, as physicians, we try to, promote health in every format, but, that, and a lot of it starts in the kitchen. So it's super great to see members of the community already participating in this. On Tuesday, we got a great lecture and got to cook together. And, we see food pantries and everything like that. And, it's just very promising to see that. So thank you for welcoming us to the community. I appreciate it. Ever since day one, I felt like we've all been very well integrated into it. And so thanks for having us.
Hey everyone, I'm Austin. If you can tell by the photo, I had a really cool sunglasses tan during that. I'm a pretty big golfer, and so I was outside a lot this summer. But yeah, just to kind of echo what my other colleagues have said, thank you for just giving us the space to kind of introduce ourselves and get to know the community a little bit better. So I'm originally from Napoleon, Ohio, which is a really small town, and it's most famous for having the world's largest can of tomato soup. And so I'm from a rural community. I've lived in a bunch of rural communities. I lived up in the Upper Peninsula of Michigan, and my travels have brought me out here. And the one thing that I can say in comparison to the different rural communities that I've lived in is that Franklin County cares. That it cares a lot. And that's the one thing that's sort of just blown me away, in regard to, just living in rural communities. Not a lot of rural communities care this much. And it's been really, just heartening to see that. In regard to, something that I wanted to focus on, to share with you guys today is just about housing access. The housing market is sort of crazy everywhere, but I think even in Western Mass, a little bit more crazy. So just to share a story on that, I was meeting with Peter Michael of LifePath yesterday, and he was just kind of telling me a little bit about what he did. And he had just kind of, slyly mentioned, oh yeah, the waiting list for subsidized housing is 8 to 10 years. And He just mentioned that and moved on with the conversation. And I was like, hold on a second, did you just say 8 to 10 years? And, you know, I thought he meant 8 to 10 months. But, you know, I think housing is integral to healthcare in itself. You know, when I'm talking to patients about their A1C for their diabetes, you know, something that I'm not really thinking about that often is, you know, what is their living situation like? How does it impact the food that they're able to make? And so that's something that I definitely want to dig into a little bit more during, you know, the rest of my time here, and I look forward to doing so.
Hello, everyone. It's wonderful to meet you all. I have the very long name up here that might be difficult to pronounce, but you can just call me Kush. I'm originally from Connecticut, and that's where I grew up, but I am so excited to be a part of this community. And I moved here not just myself, but with my husband, my son, my mom, and my grandmother-in-law. So I am very passionate about a lot of the kind of intergenerational work that you all do, and it's very close to my heart, and my whole family has been welcomed in to Franklin County in a very special way. And echoing what Austin had mentioned, I think what's a real strength of this community is that neighbors really care about their neighbors. I think it was just in the kind of first couple weeks of moving in, my car wasn't working, and my neighbor who I just met offered to give me his car to get to clinic in time. And it's something I had not experienced in all the different places I've kind of lived around the country. And so I care very deeply about the strengths of this community, which are very apparent. I would say today I want to talk a little bit about the question of healthcare access, but maybe from like a micro perspective. There's a lot of really wonderful work that's being done at the macro level to try to increase the number of providers and the resources that are available to patients. I will say as a resident, one of the things that I've noticed and is kind of a little bit of a difficulty in any healthcare system, but especially I think in more rural healthcare systems, is everyone wants to see their doctor, and everyone also wants to see their doctor, especially when they're sick. And I think that's a real difficulty, this balance between making sure we see all of our patients for their annual physicals and that we do all the appropriate screening, but that also we try to find ways to see patients when they're sick and our patients when they're sick. And that's something I think I've had a chance to do with a mixture of both preventative care and kind of urgent care visits that I have in my clinic, but it's something I'm looking forward to doing kind of more in the future as well. The one other piece about healthcare access that I've also been reflecting on is this piece of healthcare knowledge. So when we talk about healthcare, a lot of times it's the services that we as physicians, nurses, MAs, clinicians can provide patients. But I think there is also a big kind of democratization of healthcare knowledge so that patients who are already experts in their own bodies can start to kind of utilize that knowledge to then care for themselves. So I've been thinking about working with the Greenfield Public Library here to find ways to be able to connect with community members and think about this question of, outside of like all the technical knowledge of medical school, what does it mean for someone to be aware of their body? What does it mean for them to recognize symptoms? And then how do they make sense of that and try to take care of themselves outside of the healthcare system? Because that's where a lot of health happens. So in March, I will be having a session with some teenagers in the Greenfield Library talking about kind of myths on social media about healthcare and different kind of myths out there about how to take care of yourselves and how to make sense of that information so that they can take care of themselves even before they see a physician. But I'm very excited to meet you all.
Hello, I'm Dr. Muscles. At our annual holiday party, one of the MAs told me that she'd given us all nicknames, and she's still working on a few of the other ones. Pretty funny, if you met me, I am basically a fitness hammer. So show of hands, how many of you yesterday engaged in 20 minutes of sustained, moderate intensity aerobic activity, which means you could not sustain a conversation vocally?
Could not sustain a conversation.
Moderate intensity means that you would really not like sustaining a conversation, you'd be rather breathless while doing so. So we got like what, 4, 5 hands, 6, okay, very good. 75% of Americans do not even meet the minimum recommendations for physical activity. This is one of the most pressing public health problems of our day, especially with an aging population. population, you can rest assured that that 25% who do are the young ones. And then we start to limit our activity because this hurts and everything is a negotiation, getting out of a chair. So, what is my mission? My mission, I've been in the gym business for 20 years. The first thing I did when I moved to Greenfields, I walked right into that YMCA and I was like, oh, it's over there. If you see me in the clinic, I still don't know where I'm going. I walked right in the YMCA and I was like, this has been my mission from the get-go. Since I went to medical school, I came as a personal trainer, frustrated with my scope of practice and wanting to understand the whole scope of human health. And I know that exercise is one of the most potent and also free interventions that you can engage in, second only probably to sleep. So knowing this, I was really delighted that Dr. Romano, who's now on our faculty, actually negotiated free YMCA memberships to all of our providers. And why did he do that? Because he's really trying to push the Prescribed Y program. And I think it's really interesting that although we have this prescription available to us, so few of us actually remember to do it. And I can't think of a single medical condition that doesn't benefit from exercise. So my mission, when I showed up, what did I do, Dr. Bellberg? I started at movement challenge.
Got us all moving. Yeah.
And by the way, you did, you killed it, you crushed it. It's like you're doing 15,000 steps a day until you got Achilles tendonitis. Dr. Macedo was hitting the gym. We had a bunch of MAs in on the action, and what I was trying to do was show that social modeling works. When I worked at a gym, someone would start, I want to be a front desk worker, and they'd kind of come in a little soft, a little belly, a little out of shape, and within 3 months, they were like, they were tight, because everybody around them was doing it. And so that was my mission statement, to really integrate a culture of movement into Franklin County. On our Life Path presentation earlier this week, I asked, how many programs do you have right now that are dedicated to getting seniors to move their bodies? Not one. And I thought, okay, that's really convenient for me, because I just put in a grant application with Life Path to, in partnership with the YMCA, try to offer a Zoom-based physical activity and social loneliness prescription for people who are out in the hills who can't make it all the way down 20 miles to the YMCA. We'll see if I get that grant. If you know anybody, vote for me.
Okay. Thank you.
Thank you so much. It was really so fantastic to get to hear from all of you, and especially from some of the newest doctors practicing here in Franklin County, and I'm so impressed with all of your plans. And can we just give them one more round of applause? So to wrap up, I just want to say that I really appreciate you spending an hour and a half with us here today. I hope you learned a lot. I feel really inspired. I hope you do too. We want to stay connected to you. Our next progress report meeting will be in April, but we are going to do lots of things in between now and April, but mark your calendars for that time in April. And Phoebe, is there anything else that I should say that I forgot about? Okay, then we've got a few minutes for questions. I think it would be best if we just kind of mingle and network and ask our questions on our own. So grab some snacks on your way out, and thank you all very much.
Thank you.